I'm absolutely delighted to introduce Professor Mike Trunnell as the 2014 R.D. Lawrence Lecturer. Mike worked in Sydney for several years before coming to join us in Newcastle in 2006, and then followed the most extraordinary whirlwind of activity, leading through an R.D. Lawrence Fellowship, and then on to an NIHR Senior Fellowship in 2011, Personal Chair in 2012, and onwards even from there. So I'm absolutely delighted to introduce Professor Mike Trunnell, this year's lecturer.
Thank you very much, and good morning and welcome to the 2014 R.D. Lawrence Lecture, Lifestyle, Diabetes, Science Lost in Translation, on this beautiful spring morning. So, in the interest of time, I'm going to make a minor edit to my title, which is I'm going to be focusing mainly on type 2 diabetes. And that's not to say that many of the principles which I'm going to talk about aren't applicable to type 1, but I'll primarily use examples in type 2. I've now been honoured to be associated with R.D. Lawrence in two different ways. As Roy mentioned, I was a Diabetes UK R.D. Lawrence Fellow a few years ago, which laid the foundation for much of the work which I'm going to talk about today. But also, now giving the lecture, it's made me realise how much R.D. Lawrence and the work I do have in common. So two things about R.D. Lawrence that really struck me. The first was how he really began to understand the crux of diabetes and the important role of lifestyle. So R.D. Lawrence was one of the very first people to demonstrate that exercise was good for people with type 1 diabetes, directly challenging the philosophy at the time that exercise was dangerous for diabetes. And this was a philosophy in the way that he began to explore diabetes management. He was very interested in the role of food going in and energy going out and how it could be used as a therapeutic tool in the management of diabetes. And the foundation of that was the setting up of what we now know as Diabetes UK. R.D. Lawrence founded Diabetes UK, or the British Diabetes Association, at the time for patients, with the knowledge that patients' behaviour would be the key to good diabetes control. And that really is a strong resonance with the work which I do now. I'm really interested in how calories in and calories out can be used as a therapeutic tool in diabetes management, obviously acknowledging that there are some background susceptibility genetics. But the interesting thing that we're finding about the genetics is that these are susceptibility to genes, that they're heavily influenced by the calories in and the calories out. In this talk, I'm going to cover three main areas. I'll be talking about past philosophies, current philosophies, and then I'll be doing the riskies. I'll be extending a little bit into the future, where I hope you give me a little bit of license. So to start with the past, we know in type 2 diabetes that it's a progressive chronic condition. And some of the fantastic work by the UK PDS team has shown that over years, diabetes will progressively get worse. And the key driver for that is a subtle increase in weight. And there's been some wonderful work showing that different pharmacotherapies attenuate that increase. And what they do is they shift the curve to the right-hand side by about 2 to 3 years. Now, the changes in pharmacotherapies have revolutionized the way that we think about diabetes care. But what they do is attenuate the increase. They shift the curve to right. There's a pressing need for other therapies to work alongside these drug-based therapies. And if we have a look to see what's happening with the change in our body shape, this graph on the top left-hand corner shows you the years ticking by. And you'll slowly see the change in the number of people who are classified as obese, that is, having a BMI of over 30. Now, my apologies for the data from Scotland disappearing. It's nothing to do with the Scottish independence vote. It's because we didn't have audit data. And so you can see quite clearly that over 20 years, the US has gone from that lovely pale blue colour with a low prevalence of obesity to now the big change in body shapes resulting in these big orange areas. our body shapes are changing. The data from the US is probably of no surprise to you, but that was over 20 years. I'd draw your attention to the data from England, which has done similar, but in only 10 years. The challenge is not whether we are getting bigger, it's why. And I'd like to use a couple of examples now where it might not relate to the calories in, but look at how our lives are changing in more general terms. So this is one of my favorite pieces of data, cutting-edge medical research from 1953. So this is one of the foundation studies for the field of physical activity and chronic disease management. So Jerry Morris compared London bus drivers to bus conductors. And what he was able to show was that the bus drivers were twice as likely to die of heart disease compared to the bus conductors. Now, for those of you young enough not to know what these guys did, the bus conductors spend their life walking up and down the bus and walking up and down the stairs. And the bus drivers lead a sedentary lifestyle. And the more we're learning about the correlates for obesity, we're understanding that the everyday energy expenditure is really quite important. And that the change in obesity in the US correlated beautifully with dishwashers, washing machines, cars, and had weaker correlations with energy intake. And these are things that we take for granted. But maybe one of the reasons we focus on BMI is because it's easy to be measured. And we focus on food because we can conceptualize it reasonably well. But the data also extends to glycemic control. So this is some data from the OzDiab study from David Dunstan's group. And David had a look at the association between TV watching and glycemic control. To do this, he gave what we call the breakfast of champions, a pint of Lucozade in the morning, and had a look at the 2-hour blood glucose level. And you can see that the more television you watch, the less your body is capable of pushing the sugar into the muscles and the liver, or more insulin resistant you're becoming. And the data for men is also extended to women. So the things you do in your everyday life have a real effect. And I say the things that you do because it's not necessarily your patients, it's things that you and I choose to do on a daily basis too. And there's now quite a strong evidence base that if we start to explore the role of moving more, it does have a clinical benefit. And so there are 3 great systematic reviews now looking at the effect of exercise on diabetes control. And what these show is that you get a 0.6% reduction in HbA1c, which is directly comparable to some of the major classes of drugs. But one of the weaknesses in this area has been the strength of the evidence. So when these systematic reviews were done in 2006, only 189 people had been randomized into an exercise study. 189. And so it's no real surprise that when physicians are looking at the best treatment pathway for patients, they will look towards pharmacotherapy trials with thousands of people because the numbers were so small. I'm pleased to say that now, another 6 or 7 years on, the landscape is completely different. The other important role when we're thinking about BMI and things that we do in our everyday lives is sleep. This is something that we tend to forget about, but has a powerful effect on diabetes control. It also has a powerful effect on your body weight. So cross-sectional studies show that the amount of time you spend sleeping is an independent risk factor for developing type 2 diabetes. So relative to a reference sleep duration of 7 or 8 hours, sleep shortening significantly increases your risk for diabetes, as does sleep lengthening. Now, the role of sleep shortening is quite clear, because if you start to sleep less and less, I've got a 7-month-old daughter, so it's something that's very close to my heart. So if you sleep less, your body goes into a stress response mode, and as a result, it becomes insulin resistant. And you can see this if you take a 21-year-old medical student and take them from 8 hours sleep per night down to 5 hours sleep per night. By the 5th night, they're as insulin resistant as somebody with type 2 diabetes. You give them one night's sleep opportunity of 10 hours, bang, they're back into the normal glycemic control zone. So this is a very powerful tool. The interaction with appetite is also something that's quite fascinating. Because if you sleep shorten someone and then you say you can eat as much as you like, they eat about 20% more calories. Not just do they eat more, they go for the donuts, the chips, not the salads, not the healthy foods. So there's an interaction, and it makes sense because sleep is integral to your preservation. In contrast, sleep lengthening we know less about, but it may be because of the impact that it has on calorie expenditure during the day. So, in summary for the first section, R.D. Lawrence started off by telling us that what patients do is very important. And we've built a lot on that early foundation to understand that calories in and calories out and the mediators of those are really very important. And the work that we've been doing most recently has added a lot of granularity, but has really started to change the way that we talk and communicate this with patients. There's an understanding that what we do, you and I do on a daily basis, is quite complicated. So we know that your postcode relates to your BMI, your disease risk. We're understanding that the environment is a very important player in expressing these susceptibilities to chronic disease. But also we're understanding that chronic diseases themselves are interlinked. So type 2 diabetes is related to cardiovascular disease, dementia, liver disease, and that understanding how these interacting organs work is showing that you get much bigger benefit of the types of therapies that we look at, rather than just focusing on diabetes. The science is also showing that we've got susceptibilities. Some of us are vulnerable to the types of lifestyles that we lead, and some of us are not. And the complexity for us as clinical scientists is to explore these three things together. And this is a great example of the power of environment. So this graph shows you data from the Framingham study. The yellow dots are obese people. The links between them are links with other people. If you're a green dot, you've got a normal BMI. What the data shows is that you end up with clustering of obesity. Or put another way, if you're obese, your friends are likely to be obese. But the more interesting element of this for me as somebody who's interested in creating change is that if somebody moved from having obese friends to having non-obese friends, their body shape changed. Now, of course, I'm not encouraging you, if you want to lose weight, to change your friends, though some of you may wish to. But what it does show is the power of your peers. And that's where we're learning most now. But also we're understanding that the role of weight management is really pivotal. So the early acted study showed us very encouraging data that you can change people's body weight. And some of the work that Roy Taylor and the group in Newcastle have shown is not just that it improves glycemic control, it begins to reverse this progressive chronic disease. So this table shows you the first phase insulin response, which is nearly knocked down in people with type 2 diabetes. And then a greatly suppressed maximal insulin response. And that if you can help people reverse the progressive gain of weight by helping them lose weight, you restore the way that the pancreas works. It's now sensitive to the signals and has an increased maximal capacity. This is really changing the way that we think about these diseases to the point where instead of just having treatment algorithms that are progressive about decline, maybe we should be thinking about ways to bring people the other way. When we look at the science which is now around for the intervention studies, we know, as I've just shown you, that sleep plays an important role. However, we know very little about how to use it in clinical care. How do we help patients optimize their sleep duration, and what's the benefit of that to glycemic control? We know not a lot. In contrast, we've learned a phenomenal amount about sedentary behavior. And in the UK, we're very lucky to have the likes of Tom Yates, who are really specialists in this area. And what it's showing is that sedentary behaviour is an independent risk factor for glycemic control and cardiovascular disease risk. And it's independent of whatever else you do. And it's important because changing sedentary behaviour is possibly easier than helping people to move more. If we do think about walking, walking itself is a very powerful diabetes controller. Some of the work that we've done has shown that you increase fat oxidation and you can optimize the way that the mitochondria work. But more importantly, from a practical perspective, it has a real impact on glycemic control and the costs of managing diabetes. This table shows you some data from Pierpaolo De Fio's study in Italy. And over 2 years, he looked at the average change in walking per day. So the 10 is 10 minutes extra per day, 20 minutes extra per day, and so on. And on the y-axis, you've got the change in direct and indirect healthcare costs. What Pierpaolo showed is what we know from the prospective diabetes studies, that this is a progressive disease. But he built on that to show that if you don't walk much more, the costs continue to increase. But the magical point was this point about 30 minutes. At this point, glycemic control improved, but also the cost for managing diabetes went down. So the amount of drugs that people were taking went down. Their visits to primary and secondary care went down. So it had a real impact. And most recently, we've been able to understand the role of different forms of exercise on diabetes control. And what we've learned there is that a whole array of different types of exercise work. Resistance exercise, high-intensity intermittent exercise, aerobic exercise. And that gives us great opportunity to work with patients because we know that these all confer benefit to patients. And some of the work that Ron Segala has shown is that more is better. And so the question I get asked most is, which is best? To which my response is usually the one you enjoy and the one you're likely to do. One of the other questions that we get asked routinely is about physical activity and weight loss. And this is some data combining some of the work that Roy's done with people with type 2 diabetes and some of our data. And this is showing data in change in liver fat with resistance exercise. And you see a significant reduction in liver fat with resistance exercise, which is great from a hepatological management point of view because there are so few ways to manage liver disease. But compare that with the effect of a low-calorie diet. So there are ways that these can work next to each other. And maybe the role for an active lifestyle is not around weight loss. In fact, we know that exercise and an active lifestyle on its own will not induce weight loss. But what it's very good at is preventing weight regain. And the challenges for us are how we try and use this on a big scale. And we know we should use it on a big scale because we look at big populations studies and they show us that these things work. So this is data from Cuba in the economic crisis. And the zone in red shows the period of economic crisis. Now at this time, not surprisingly, food became sparse, so calorie intake went down. But also the cost of fuel went up. So the Cuban government, in their wisdom, gave everybody a bicycle. If there are any policymakers here, this might be a good idea. What they showed was that the number of people diagnosed with type 2 diabetes, shown in green, significantly went down. Now, obviously, there would be an effect of less detection, but that's a profound change. The other line in red is diabetes complications. And you can see that it went down and there was a little bit of a legacy effect. The other point I would like to make is that when people started eating more and moving more, the green line, the prevalence for diabetes, rebounded. And it came back to its original level. If not, it's still on the same trajectory that it was before, showing that we need to find ways to create sustained change. And we know not just that we can create change, because if we look at data, studies like the US Diabetes Prevention Study, you can significantly affect the number of people who go on to develop type 2 diabetes. So this is the placebo group, years from randomization in an at-risk group along the x-axis, and the incidence on the y-axis. Metformin had a significant effect on the number of people to go on to develop diabetes, as did some of the TZD therapies. But lifestyle had by far the biggest effect. In fact, if you look at the effect of metformin versus lifestyle, lifestyle was nearly twice as effective. So the challenges for us are how we put these into clinical care. And there are a few things and a few points from a research perspective that are worth raising. I wanted to take this opportunity to talk about the recent paper from the Look Ahead study, because the science of lifestyle in the management of diabetes is exceptionally strong. And there are some elements to this which are really challenging. So the recent publication by the Look Ahead group that showed that lifestyle intervention did not affect cardiovascular endpoints. Now, this was a really interesting example that I think we can learn from. What it shows is that we're exceptionally good at managing cardiovascular disease events in control groups and in people with diabetes. The study was stopped because it wasn't achieving its endpoints, because we were so good at managing cardiovascular disease. The way that we managed it changed dramatically. So if we're going to look at long-term studies, we need to incorporate the fact that we're getting better at managing chronic disease. It's going to be really interesting to see how the other outcomes work from this data set. But my caution with this is that the study was underpowered, and that was why it was stopped. It wasn't because lifestyle did not affect cardiovascular disease. And as a result, we have lifestyle embedded in our current treatment pathways. So this is a cartoon representing the treatment pathways. You get identified as having or being at risk of having diabetes, either through a health check or through your doctor. And then you're given generic advice on lifestyle management. And they see you every 12 months. You go through that cycle until you cross the magical threshold where you develop type 2 diabetes. At which point, the same happens again, but now they'll see you every year. So we really have to challenge these cycles, and that's where I'd like to put the attention in the last section. And so it's clear that when we're talking about complex disease, we need to think about these multiple layers. Now, I'd like to finish with a forward-looking view of some of my perceptions on how we should begin to challenge these. And so, to this point, I've been really lucky to have a lot of support from some fantastic people. In Sydney, Campbell Thompson and Carolyn Sue taught me about the importance of thinking about the body, the interaction of different lifestyle, and also the importance of genetics. Roy, who's been integral in my philosophies on science, but also making sure that the science that we do is exceptional. Doug Turnbull, who's supported me in thinking more about the basic elements, but also the team who stand behind me. Or I probably stand behind them, because the science that we do is led by them, not by me. And so, looking forward to the future, could I just ask you to read this paragraph, first of all? Now, could I ask you to count the number of Fs? F for Freddy. Now, when I say the number of Fs that's right, could I ask you to stand up? And by the end of it, we should have everybody stood up, I hope. So if there's one F, that's a great start. 2 Fs. 3 Fs. 4 Fs. Stay stood up. 5 Fs. 6 Fs. More than 6 Fs. Okay, so we've got everybody now. So thank you very much. So this is not a trick. It was a way to challenge the way we think. And at the moment, you don't care what I'm saying. You want to know how many Fs there are. And congratulations, those of you who found 3, but you missed the other 3. There were 6. Now, the reason for using that as an example is because our bodies, the way our minds work, we're pre-programmed to do things automatically. So we don't read ofs. And in our everyday lives, we do things automatically. So how we get dressed in the morning, how we brush our teeth, the food we choose. We think we make our own personal choices, but they're automatic. And when you're meeting somebody in the clinic, you're already working through your routine of how are they looking. You'll have seen the biochemistry data. You'll have made a lot of decisions about that management pathway. I'd like you just to put those to one side for 2 seconds. And also, any perceptions you have about lifestyle, also put that aside for 2 seconds. And then let's just talk generally about why and what we're doing. So, historically, there's a perception that we make our health decisions consciously and on our own. So if I give information to you, you're likely to do something. What we've learned from some of the best practice behavioral science is that that just doesn't hold true. And that your health decisions are being made by groups and by your peers. Whether you walked here this morning or got a taxi or a bus was determined in part by the people who are around you. When I go out for dinner with my male mates, the choice of whether I have a lime and soda and a salad or a red wine and a big pint of beer is part of me conforming to those groups. And that if we really want to challenge behavior, we have to equip patients with the ability to interact in that environment. Because we might see patients for 10 minutes, but for 5,840 hours of the conscious waking year, they're making decisions on their own. And we know what influences behavior. And this is an example from one of my friends, Adam Wotton at Zenfund, who talks about how you engage people. And that you have your heads, your hearts, and your hands. And we all know we should do things. We've got the ability to do them, but the thing that we miss out is connecting with people emotionally. And that we normally work in 2 of these zones. So if you've got your head in your hands, you procrastinate, which is what I think a lot of our patients are. They know they should move more. They've got legs, they can move more. But that tie-in isn't there. You can also end up with heads and hearts where you get stressed because you can't do things. But the point where most of us spend our lives is in this impulse area where we don't think. So our challenge is to give people the tools to allow them to think and make them want to think. And there are some good examples of that. So those of you who are old enough to remember sorting cards when you were looking for scientific journals. Those of you young enough not to have this, you used to go through an index system to pick out the card for the journal you wanted. You walked over to the journal to then photocopy it, only to find out that some person before you has ripped out the journal article you wanted. So now we don't do that. We go into Google Scholar, we go into PubMed. We've got knowledge at our fingertips, and we get frustrated if we can't download the PDF in 4 seconds. Or maybe that's just me. We look at how we work socially. We don't send postcards anymore. We send notes through the social media. And that's very true for younger generations, where the philosophy of that I do something and I share it with my friends through social media. And the way we're communicating is really changing. And I think there's a great opportunity for us to influence the group behaviors by using some of these newer technologies. We're also developing tools to challenge professional and patient behavior. I say professional first because I think some of the major barriers to lifestyle are actually not with patients, but our perceptions towards it and how we deliver it in care. And so we've worked with primary care teams on how you can optimize getting training packages into their everyday life, and also with patients. So for the majority of patients with type 2 diabetes, the key insights we got were that diabetes was a small part of their life. And so that if we wanted to engage with them, it had to be about things that they cared about. And they cared about being happy, looking better, feeling better, and having more energy. And so if we are going to take these interventions, we need to connect with that, which resonates with the heads, hearts, hands message. And so through this, we've developed the UK's first accredited online professional development pathway. It's been evaluated in a cluster-based control trial in primary care, will be available later this year. This involves patient behavior change material. And the feedback we're getting from it is that the professionals were skeptical about using it at first, but now really enjoy it and are surprised that the slight changes we gave them were useful. And the same for patients. And there's lots of really good behavior change programs and education programs out there. The challenge for us is how to roll these out into care. And this isn't a new problem. So if you look at the Beveridge report from 1942, they were looking at trying to understand how you could help patients live wellness programs. And they were trying to look at the overall health of the UK. And they came up with two recommendations. One, there should be a system that managed chronic diseases and managed disease and manage the complications of it, and that should be available to everyone. That's now called the NHS. The second part was that there should be a lifestyle management or a well-being management system that should be part of the responsibility of the employer. They decided that was too hard, so they built the NHS instead. But we still have the problem that this well-being management infrastructure just isn't there. And so I challenge you to think with 6 Fs. When you go back to your clinics, you can have a real and meaningful impact on diabetes care. And I think lifestyle is definitely one of the cornerstones of its management. And so, to finish the talk, I started off by showing that diabetes is a chronic disease and that pharmacotherapies have had a significant beneficial effect, but it did not reverse the process, and there's a pressing need for other therapies. Lifestyle is a powerful diabetes management tool. We should be using it, and we should be optimizing the ways to deliver it. The third point is that behavior is really complex. But actually, there's some very simple things that we can do. And the challenge for us is to engage patients by giving them information, tools, but also connecting them with what they're supposed to be doing. So lifestyle and diabetes. The evidence is strong. It's up to you and me to translate it. Thank you very much.
Ladies and gentlemen, I'm sure you'd agree with me that this is one of the great R.D. Lawrence lectures, elegant and highly relevant for our time. So it gives me great pleasure to present the certificate and check to Mike.